I'm humbled to come here, and thank you so much for inviting me. I'm actually a little anxious, so bear with me, but thank you. It's actually the very first time that anyone, I think, first time that anyone from the Royal College of GPs has ever addressed a conference on ME, and thank you very much. And it's actually your chairman, Kathleen, who I understand is ill, but it's her and I that got on communication through Twitter, as I tend to do for many of my communications, and I'd like to just express my thanks to her, and if anyone can get that message through, because I think what she's done in inviting me, I think, was actually quite brave, and I think actually very, very forthcoming in terms of building bridges between what amounts to the largest Royal College in this country and a very, very important problem that face many of our patients. As I said, it's important that we start to build bridges because we're all here really for the same thing, aren't we? We're all here to improve the lives of our patients, whether those patients have ME, heart disease, diabetes, schizophrenia. We're all here to do the same thing. And in particular, we're here to improve the lives of our patients who have long-term chronic disability. I did a surgery this morning and I had a clinic full of patients with long-term problems. But first, though, I'd like to tell you a little bit about myself, a little bit about my college, and a little bit about general practice. I'm actually the chair of the Royal College of GPs rather than the president. Our president is like the Queen, a sort of titular head.
I meant it.
And I'm like the Prime Minister. The college is there to raise standards and quality for the profession, not just in the UK, but across the whole world. Our role is to be the voice for general practice so that we can promote the unique doctor-patient relationship, so that we can shape the public health agenda, set standards, promote quality, and advance general practice globally. And in a minute, I'll tell you why that's important. As I said, our college, which is a charity, is the largest of all the Royal Colleges in this country. We have about 48,000 members. But we're also one of the youngest. We celebrated our 60th birthday just last year. I'm proud that I'm only the second female chair in our 60-year history. I demit office in November, and quite surprisingly, I'm going to be replaced by another woman, which is very good, Maureen Baker. Over the last 3 years, it's fair to say that I've witnessed a lot of change in the NHS. And one of the most significant changes has been the progress and the implementation of the NHS Social Care and Health Bill, Health and Social Care Bill. Have many of you heard of it? And I'll be talking about this in a little while, because actually it is very important to how our services are going to be shaped and how many of our patients will receive their care. But if you'd humour me, I'll first put myself in context, because I think sometimes it helps to see where somebody comes from and actually where they are then with respect to their profession. I'm proud to be a GP, and I'm proud to be leading my profession. Who would have thought that the daughter of a first-generation immigrant would be standing here as the leader of such a great college? My father taught me to work hard. He inspired me. He himself was a single-handed GP in Peterborough, and we lived in the heart of our practice area, as I do now for the last 25 years. But unlike my father, my surgery isn't in the front room of our house. He would take me on home visits. I think something that would be probably frowned upon nowadays, to take a 10-year-old into somebody's home. But he would take me on his visits to what was then the post-war slums of Peterborough, and he showed me firsthand the effects that poverty had on people's lives. And he taught me, and I remember this, and I stick with me, that to be a good GP, you had to give something back to your community, you had to listen, and you had to be there. And I hope that I've managed to live my professional life with those three things in hand. General practice is the oldest branch of medicine. Family doctors in this country carry out around 90% of all NHS activity for only 9% of the NHS resources. I'd be interested to hear what it's like in Sweden and Denmark. Most children in this country never see a paediatrician. Many elderly people never see a geriatrician. Many people never see a psychiatrist. Most individuals see their GP at least once a year, but average consultation rates, even back in 2008, were about 5 times a year. And if you're over 85, you consult around 20 times per year. In my practice alone, we see 300 people per day. And across the whole of the NHS, we're seeing more than 1 million people every single day. We are the pulse of the nation's health. But I'm sure you've seen lately that general practice is under strain. And this strain, ladies and gentlemen, will impact on you as patients and as users of the NHS if we don't sort it out. We're being blamed for the failures in everything, from the care of dementia to the most recent debacle, the problems in our emergency departments. And I am personally sorry that GPs cannot deliver the sort of care that patients want and need. But without being defensive, it's difficult and demoralising at times for our profession, as we're being battered by our political leaders and the press and by some of the patients we serve. We are bearing the brunt of the cuts, the expectations and the failures in the system that's under pressure. We're bearing the brunt for the inability to deliver personalised care at supermarket prices, because after all, that's what current funding is about. So when people want my doctor when and where I choose, but we don't have the resources in terms of money or manpower to deliver that, and I'm sure some of you feel that on a daily basis. However, general practice is what makes the NHS work. It's what makes the NHS fair, accessible, and value for money. And the key strengths of general practice means that it can provide person-centred, holistic care that patients value greatly. And despite the battering we've received, we are still the most trusted profession. The care we provide is highly cost-effective. I was telling you how GPs make the NHS fair and effective, and what we do. The tools of our trade are listening and the continuity based sometimes on many, many years of looking after you. It's also based on having our patients registered with us, traditionally from cradle to grave, but I accept that with a 40% turnaround that we see in London, it's often sometimes just for brief snapshots of their lives. But nevertheless, we provide the totality of the care whilst they're with us. Of course, it's not just GPs that are under pressure, but the whole of the health service. And again, some of you who've tried to attend specialist services recently will find that only too acutely. All over the world, health services are under pressure. And all over the world, health services have to address a certain number of problems. First, the rising demand from our ageing population. I apologise to those that are getting older. Actually, our ageing population is our success, and we need to celebrate it. But nevertheless, it does put pressure on our healthcare systems. As we age, we also have more complex problems, and we're likely to have many, many conditions, not just one. Half of all our appointments, of all GP appointments, are with patients with multiple morbidity. We also have the pressures of trying to develop models of care for patients with complex and chronic diseases, so they aren't salami sliced into their individual problems and end up going to multiple carers within the hospital system, where one then spends one's entire day going from one outpatient to another. And of course, every healthcare system has to deal with the financial crisis that we're all in. In the UK or in England, I'm sure you know, we have this great euphemism called the Nicholson Challenge, which rather puts a sort of nice fuzzy sound to what is actually quite a problem that we're all facing, which is making significant cuts in real terms in resources in the NHS, with savings over £20 billion expected over the next 4 years, and that's at a very minimum. But even though we have these challenges of our ageing population and challenges of finances, it mustn't detract us from what matters most to patients, which is delivering continuity of care. Continuity is important to effectively manage any chronic condition. Continuity of care built up on having regular contacts with our carer, our doctor. But in providing continuity, what we must do with our patients and with their carers is fully engage you in your care, control your disease and manage symptoms and complications, provide information to you and your carers about your condition and any new therapies that emerge, engender skills and confidence in you, and provide ongoing motivation and support to all of our patients so that you can assume the primary role and motivation for the day-to-day management of your condition. But how are we going to achieve all these? Much of the debate around the health and social care changes has been focused on structural changes, meaning that at times it's been difficult to drill down into what these reforms really mean and how they're really going to deal with the challenges that we all face. The only way to deal with the challenges is to develop services that are integrated, the I word, around the needs of patients. And by integration, what I mean, what my college means, is GP-led, multidisciplinary teams, ideally with a shared budget, and ideally using a single electronic record. But we're far away from that, and many of our patients have fragmented care. So what about this bill? If you cast your mind back to 2010, we were promised no top-down reorganisation. Do you remember that? Yep. But instead, within days of the last election, we got a monumental reorganisation. A reorganisation that was so large that the current chief executive of the NHS, who's actually now the outgoing chief executive of the NHS, Mr. Nicholson said it was so large you could see it from outer space. And indeed you could. A reorganisation, ladies and gentlemen, that has dismantled every existing structure around health and social care that we had and rebuilt them, and en route losing 16% of staff that worked with these relevant bodies. A reorganisation that's had to be done at the same time as making these monumental cuts in services, which I was talking about. A reorganisation that was pushed through at breakneck speed, such that it was completed before the bill actually passed through its parliamentary processes. Having done that, it's caused exhaustion and demoralisation amongst those that have been part of this process, and I don't know how many in the audience have work in the health and social care sector, but I'm sure you too are exhausted and demoralised at having to have gone through it. Someone once described the NHS to me as an old rambling estate, needing constant repair, but fundamentally sound. The reforms have dismantled this estate, and in doing so, destroyed its foundations. And the people that have done this have now discovered that in their rush to demolish it, they didn't really fully understand what went on in some of its rooms. Important functions that never met the public eye, functions such as emergency planning, training, resource allocation. All these have now disappeared, maybe to be rebuilt, maybe not. I'm sure that many of you know some of the high-level changes that the Act brought about. I'll tell you a few. Responsibilities that historically were located in the Department of Health now fall within the politically independent NHS Commissioning Board, which got renamed just last month to NHS England. Primary care trusts have gone, and in their place are CCGs, or clinical commissioning groups. And GPs have been put in charge of commissioning. All practices have to belong to a CCG, and therefore by this process, all patients on a GP list belong to a CCG. CCGs vary in size from the smallest at around 100,000 to the largest at just over 1 million patients. Commissioning is a confusing concept. We're the only country that does it. It's actually the process of buying healthcare for populations. It involves a complex system of identifying priorities, determining need, establishing criteria for contracts, tendering, awarding the contract, and monitoring the contract against key performance indicators. The whole process of putting out a service to tender can cost at least £250,000 and can take 18 months. Around 60 billion of healthcare resources will be commissioned by CCGs. What isn't commissioned, which may interest you and you may want to see if the services that you work in are commissioned in this group, what isn't commissioned are highly specialist services, so very high cost, low volume services. And what isn't commissioned by CCGs are primary care, optometry, dentistry, and some other community services. These are all commissioned by NHS England. All the other big aspects of the NHS and social changes, one of the other big ones is moving public health to local government. And with it, prevention activity and commissioning for drug and alcohol services, sexual health and smoking cessation. It's early days yet, and no one really knows how the reforms will work. But what is good about the reforms, and I've said this from the outset, it's right and proper for GPs to be at the centre of planning care for their local populations. I've already said to you that together we see over 1 million people per day. So after all, we are best placed to do this. But whether GPs have the skills, knowledge and expertise to do this very complicated job is in doubt. For you, it's important that commissioning groups understand how to commission services for patients with ME, because otherwise you may well be left out. And being such an important condition, it's important that you're involved there. I know from personal experience, but also working at the college, how few GPs understand the condition and how few have the experience of treating a patient with ME, let alone commissioning services for groups of patients with ME. The college is trying to sort this out, certainly on the management, not necessarily on the commissioning side. And we have very recently launched an e-module. I know nearly 500 GPs in a matter of weeks have downloaded that module and undertaken a very good, very rigorous training package lasting up to an hour on various aspects of chronic fatigue. If the NHS Act is going to make sense to patients, or to providers, or to commissioners, it must translate to better care, delivered closer to home, and built on the strengths of existing providers. What we mustn't have, and again this is your territory, is your services dismantled as GPs develop the skills and knowledge to work out what to do and how to commission those services again. For patients with ME, the new NHS Act will hopefully translate into better care and better informed GPs. GPs who are better able to commission services and better able, therefore, to have services that meet your needs. But we need your help in this. As I said at the beginning, many GPs will not have the experience of managing the problem, let alone commissioning. For you in local areas, it's important that you get involved either on patient participation groups or on the local health watches. I'm sure that's not a plural, but you know what I mean. Or directly with your clinical commissioning group. Because otherwise, I fear that in the melee of this transition zone, this transition period which has been going on for so long, your needs may well be left out. But rest assured at the college, and the reason I'm here is because I know how important it is. And I hope that today marks the beginning of us better able to work with you in order to improve the care that you receive from my profession. Thank you very much.
Thank you, sir. Thank you very much indeed. And I'm sure we could take one or two questions, and I'm sure people want to ask. Yes?
I wanted to make a comment. The current health changes were trialled in New Zealand with GP commissioning. They were brought here to the Treasury by officials who had done that in New Zealand, and they're called the New Zealand system in the Ministry of Health. The head of commissioning is a New Zealander. The results are very clear. The reasons were very clear. They couldn't get doctors to buy into the market system if they didn't give them a cut of the financial interest. That is actually what commissioning does. It turns GPs into tradable businesses. Of course they don't have the ability to run the commissioning, so they pass it to American managed care organisations in which they're shareholders. If you want to know the results, it's very clear. Costs escalate, services decline, waiting lists get longer, and the owner doctors become extremely rich, as opposed to the worker bee doctors who are not owners of these practices. And this is what Treasury believed would be the efficiency gains of bringing this system here. It's been trialled. It's very political. It's all about money.
Yes and no. It's quite complicated, but actually the New Zealand system is different. They have groups, they have a system of primary care rather like what we had under PCTs, which is groups with an overarching structural management system. And New Zealand, as in Australia, is fee-for-service, so they already have a pay-as-you-go type system with underpinned by insurance. And what the lady at the back says, and I think I understand, it's something called sale of goodwill. GPs are independent practitioners, but we are not private practitioners. And it's really important that it's a difficult distinction to make. But when the NHS was set up, way before I was born, I think there was a bit of a row with the doctors. And in order to get over this row, Bevan and Beveridge said, OK, hospital doctors can carry on doing their private practice, 1 or 2 sessions a week, and GPs, you can stay being your little businesses tucked in your local communities. Instead of receiving direct payment from the patient, which is what it was in those days, you'll receive it from the state. But in return, you're not allowed to do more than 10% of your care privately. Most of that is around private medicals and mortgages. But other than that, you must be, in a sense, completely and utterly paid for through the state. So we're not private. We cannot sell goodwill. I cannot sell my practice. I might be able to sell the building if I own it, but I can't sell you registered to me. A pharmacist can. A pharmacist can, and many shops and businesses sell on the fact that of the profitability of their organisation. We can't trade on the stock market. We can't cherry pick our patients. So in a way, you're not right there, but you're absolutely right in the second bit, that what the reforms do is opens up our NHS, and you will see it it will open up the NHS not just to EU competition law, but more scarily free trade with the USA. Now, that's quite complicated, but what it essentially does is it opens up our health service to an entire market. Now, many of us that were concerned about the NHS reforms tried to tell the patients this and to the public, but it was seen as scaremongering. Because everybody in this country, unless you are over the age of 80, 70, has been born and brought up within a socialised health system where we pool the risk, the sick funded by the well and the rich subsidise the poor. And none of us really wanted to believe it was going to turn into a virgin healthcare or have our utilities outsourced to a German company. I'm still slightly optimistic. It must be the Prozac in the water. I'm optimistic because the people, us, it is the last thing we own as a society. We don't own anything else. We own the sky. I think we still own some of our roads, but we don't own our water, our electricity. We don't own our railways. We don't own all these. And you want to keep it. It works. It is fair. The patients I saw this morning, I saw according to need and not according to how much money they had in their pockets. And general practice, and I know some of you will disagree maybe, into you want to choose your GP. Please choose your GP, but I will never agree with you choosing your GP outside your geographical area, because it is the last leveller of society that Mrs. Bloggs, who earns a bucket load of money, has to sit cheek by jowl next to Mr. Z, who's got drug misusing problems. They have to sit together, and it is the last place, I think, that people sit together, irrespective of. And if you can choose to come and see me in, Rich Vauxhall or wherever. So you're right and you're wrong, but thank you very much.
Okay, that's very good. I'll take 1, 2, 3, okay?
My daughter's been very severely affected for 13 years. I was encouraged by this morning's speakers because they have an understanding of the illness that my daughters have. My experience is that the local GPs have nothing like that understanding. In fact, they have been taught that ME is a mental illness. The image that came to me at lunchtime is that trying to bridge the gulf between the understanding of the researchers we've heard from today and the local GPs who actually are responsible for my daughter's care is a bit like trying to build a bridge over the Atlantic Ocean. Frankly, I would have been much more interested to hear about the content of your e-module to train GPs in ME, and I wonder how far it's going towards a fundamental change of attitude. A change of attitude doesn't really cost any money, and frankly, it won't matter what structures we have or how they're financed. If we do not have that fundamental change of attitude, nothing will really change for people with this appalling illness.
Thank you. Second back row, yeah, and then we'll come over.
Well, I'm from Belgium, and I'm interested in what's in the e-module.
I'm very happy to. I've got it here. It's an e-module that acknowledges the impact of symptoms, looks at how we collaborate and support and work with patients. It looks at how we can provide patients with services closer to their home, domiciliary services and alternative modalities to coming to the surgery, and also how we can provide services that best meet your needs. So in terms of using e-health, telehealth, because of course if you're suffering from ME, it's very difficult to come to the surgery. We also look at guided self-management, helping patients manage their own conditions, and self-care. We look at helping patients support in shared decision-making, helping to address some of the long-term issues of it. We look at looking at how to provide the right information for you, the support at the right time, support for carers, medication to relieve symptoms, and how to refer to specialist services in the area. So that's one aspect of the module. We've then got other aspects of the module that look at how we unpick some of the symptoms and discuss some of the symptoms in much more detail. So fatigue, sleep problems, pain, cognitive dysfunction, stress and anxiety, diet and nutrition. So again, and then we have another module looking at the various specialist services that exist. So the MECFS services at Barts, King's College Hospital, Royal Free, and the Royal London Hospital for Integrated Medicine. So that, I mean, you can't access it because it's a membership-only system, but if you've got any GPs, they can access it as long as they're members of the college. So it's a module that's been developed. It took us about 6 months to develop it in partnership, and it's there. As I said, nearly 500 GPs in the space of 6 weeks have downloaded it, which is a lot, I tell you, to get 500 in that space of time for a subject that isn't part of our contractual arrangement. It's not diabetes and hypertension, which a lot more would download. So I think that's very optimistic. And the lady sitting over here, yes, you're absolutely right. Absolutely right. It's important to have an attitude change because it's important to respect the patient where they're coming from. But with respect to the research that you had this morning, I don't know what causes motor neuron disease, but it doesn't stop me managing my patient kindly, effectively, and with compassion. And I think that's what we need to be moving towards, and not saying the GP needs the knowledge. I saw patients this morning. I had to Google on the internet to find out anything about their condition because I don't know. But the generic issues of how to manage patients, as I said, competently, kindly, and with compassion is what's important for my profession. And that's where you've got to help, because I think if we don't build bridges, and it is my GP says it's a mental health problem and I know it's not, what's the point? What we've got to say is we have a patient who has a number of symptoms that we need to deal with in a competent, confident and compassionate way.
How are we going to monitor that then? Will the patient have an interaction with the local GP commissioners or whoever, a subcommittee of it or something, who says it's happening in Suffolk but it's not happening in Norfolk? Because that's what happens, as you know, Clare, in the health service. It's never universal because it's difficult. You know, you need the people to push it. How are we going to monitor that and chase it?
I don't know.
I don't want the Mail on Sunday to do it, you see.
I have no idea. I think the NHS is in such a mess at the moment.
Yes.
It's, as I said, it's like dismantling the house and there's 3 walls missing. And we've still got all the people having to cook Sunday lunch in it, you know.
Hi. When you talk about building bridges, when you made the E-module, did you do it in collaboration with any of the patient organisations for ME in the UK?
Okay,
I'm looking at my policy lead. I'd have to look at that. I suspect we did because we always involve key stakeholders in all the modules that we do. But I'm afraid I'd have to. It's been a busy time the last 3 years.
As a parent of somebody that has suffered for the last 7 years and is totally bedbound, I would first of all like to thank you as a representative of the NHS for addressing the conference. So first of all, thank you very much for having done that.
Absolutely.
I think I'd also like to express appreciation for your aspiration of the way in which a GP should operate. But I would like to reflect back to you that it is certainly a long way from my personal experience of operating with GPs who do almost exactly the opposite of what you have described. They do seem to not take responsibility. They do seem not to visit patients and leave them lying in their beds and in their darkened bedrooms for months, if not years.
What would you like the GP to do?
I would like the GP to do exactly as you've described. I'd like the GP to actually take a genuine interest and to take responsibility for leading the treatment as opposed to the patient and the patient's carers having to take that responsibility.
And I agree with you. My worry is that it probably falls well outside the expertise of an average GP, and that's the problem, is that we're generalists. And if if your son or daughter had another chronic complex disease that was causing such disability, we would ask the specialist to take over. It is, as a GP, and I say this to many of my patients, I don't have the skills. And the problem about general practice is it becomes the risk sink, and that's why I think so many people are angry, because actually we can't provide the care that your daughter needs, because we don't have the skills, 2, we may not have the resources, and 3, where are the experts that can then provide the wraparound services?
Okay.
There
Sorry.
are no, but then how, if there are no specialists, can my profession be and if there are no specialists in motor neuron services, how am I, as a GP, now this means GP as a provider, maybe GP as commissioners might be different. So again, I think the reason people are angry at the moment is they turn around and want to be cared for, and when there isn't somebody to care for them, they look at the people that should be caring, and they look at their GP, because the GP is usually the closest. I don't know how to manage. I had a patient who had was in bed for quite a while. I didn't know how to manage them.
Okay,
I'm not disputing whether it's physical, neurological, or made in jelly. What I'm saying is that I want us to move on from there. What I'm saying is we have a patient with symptoms and disability. What we have to do is make sure we manage that patient compassionately, competently, and with kindness. But I'm not competent to manage a patient with complex disability. I need specialists. And where we need to be helping, and you need to be helping us, is to lobby for specialist services to help manage patients.
Yes, and
well done.
and my question sort of overlaps with what's been said, because I was going to ask you what the Royal College could do to see that GPs fulfil what I see, and I don't think you've answered it, their professional obligation to educate themselves about ME. But now that you've got your e-learning, my question is, with their increased knowledge, will GPs join patients to press for correct diagnosis, good biomedical research, and better treatment? And will we see an end to statements like, I don't believe in ME? And as my partner's GP said to her, you'll know more about ME than I do. Well, my partner, who's sick, has gone on the internet, and she knows a hell of a lot about ME, and it's all out there. And we've both asked our GPs to come to this conference for years, and they haven't. And that's why we're angry. And a friend of mine was advised to go to the gym. This is the sort of thing that's happening.
I go to the party conferences, and at the party conferences I get lobbied, whilst I'm there, probably by 100 different disease groups, charities representing diseases. And there are, and I looked it up once, there are 115,000 separate DSM-3 and the ICD-11 diagnostic categories. As a generalist, I cannot know a lot about everything. All I can know about is what I've said, is how to deal competently and confidently and with compassion at the bits in front of me. I wouldn't expect a GP to come to a conference such as this. This is very, very specialist knowledge. What I would expect a GP to do is to not make comments like the one that you said, because that's not good medical practice. But yeah, absolutely. But I also would say that of course you know more about ME. My patients with diabetes know more about diabetes, of course. But they do. Of course they do. I say to my patients who have chronic complex diseases, they know far more. We've been encouraged. It's called the expert patient. Shared decision making. Of course you know more. I know more about my son's diseases than any GP because it's important to me. It doesn't mean we can't work together. But we're not on opposite sides of a spectrum. We're there in order to support you and the carers in the...
Well, come on.
But I've got 700 diabetic patients. When am I going to find the time? I've got one patient with motor neuron disease. I've got 40 patients with Parkinson's. You have to... I wouldn't come, if you're, the agenda wouldn't meet needs of a GP. It's a very specialist agenda, looking at some of the in-depth research that's been going on that clearly all of you are expert at. If the basic knowledge of a GP is how to address the problems and the symptoms, then this conference would not meet their learning needs. I'm not saying we shouldn't put a conference on, and maybe this is what we should do next year.
Just a second. I just want to say this. Listen, please. I mean, we have a GP who's come to this conference and is prepared to speak and answer. So please treat them with some respect. I mean, it's not an individual thing. She's trying to represent a position which she understands from practice. And, don't just tear her apart. I mean, that's not the attitude we want. Ask questions and make sure they're not repetitive. I'm sorry. I mean, we know the problem, right? Let's ask some questions which will make the thing move forward a bit, please. Okay. We know the problems. Please, yes.
Thank you very much. Can you hear me? Okay, a GP is a generalist and cannot really be expected to attend every conference about every disease that he or she is in contact with. And that is why it is so important to get that ME module right. Now, I heard a lot about competently managing, but I didn't hear so much about diagnosing. People who are listening to me this morning will remember that I said that there was a strong possibility that a third of the people who are diagnosed with fibromyalgia or ME actually have hypopituitarism, which is a treatable illness. It is not just manageable, but a person can lead a normal life if they receive hormone replacement. Sorry.
Get your question in, please.
So my question is, have you warned GPs of this high possibility? And are they primed to test people properly for hypopituitarism before they consign the patient to this endless half-life?
I would advise GPs not to make a diagnosis, but refer to a specialist. I would actually say that it is a specialist that makes. We would pick up some symptoms and then refer appropriately to get a diagnosis and appropriate investigations.
So are they told to refer the patient to an endocrinologist in the ME module?
No, they're not.
Hi, I just want to say I don't think everyone gets angry at the GPs. We all know that they are general practitioners, and I don't think people are directly angry at the GPs because they don't know everything about ME. I think we all understand that they don't know everything about a myriad of different diseases and illnesses. It's not getting angry about the ME. It's people get angry when they are turned away and made to feel that there is nothing wrong and they're not being listened to and they're not being forwarded on to specialists. I think that's what people get angry about.
I think that the lady at the back, you're absolutely right. And thank you very much for saying that.
Right, yes.
I'm interested, and thank you for coming. I really appreciate that as the mother of somebody who's been very ill with ME for 10 years and has lost most of her developmental phase. So it's critically important to me. My son has just completed his first year at medical school, and he can expect to receive no education at all, I believe, which is sensible biomedical information about this condition. And that distresses me because one day he will be a GP, that's what he wants to do. But he will not have been given any of this medical background that we patients are finding out about. He'll have been given none of that in the course of his formal medical education. And whilst I appreciate nobody who's a GP can be an expert, it seems to me that GPs treat patients with heart complaints having been educated in great detail about what is currently known about heart problems, but absolutely nothing about the condition which his sister has.
Okay. There's two young medical students here. Have you ever heard of ME in your training so far? Say who you are, please.
Yeah. Thank you for your comment. I'm Caroline. I'm a medical student at UEA. I'm final year. Education varies significantly between medical schools, but at Norwich we are taught about ME in two separate units. We cover it with fibromyalgia in our first unit, and we cover it with in our psychiatric unit as well, looking at how to manage non-organic disease. And we also, throughout a variety of and that isn't necessarily the best place for it, I understand that, but we are taught to manage it in a caring and compassionate way, which echoes. We also have the fortune to meet patients with ME and CSF, and we learn from them because I've learned more from them than from any other way, because you are the experts, and we do find that of benefit.
Speaking as a Somerset GP, and there are two of us here today who have developed a paper to try and help the clinical commissioning group to move forwards. I think we are interested. We recognise that we need specialist services in this area, and there aren't enough specialist services in the country. And that's why we have come today to help that process move forwards. I'm very aware, Mr. Chairman, that time may have moved on into our next speaker's time as well, but that's your prerogative.
No, I think this is quite good, actually, because, I mean, people have come to say what they want to say, and we're learning. You know, the people here that set this up want to know. Sir, up the back.
Thanks. I just want to say that thank you for coming very much. I'm a paediatrician, and I run an independent clinic for children with ADHD, and I've done it for 20 years. And I thought it was worth mentioning that because I think it's a parallel hidden handicap in the same way. 20 years ago, I was so frustrated with the lack of awareness of ADHD, I started an independent clinic, and that's still going. But the problem is that people can't come to us on the NHS because it's blocked almost to anti-apartheid. We're pushed into a private market. So in terms of you trying to provide specialist ME services, unless the commissioning changes so that you're able to commission for ME services through the NHS, I mean, in my situation, I know I provide cheaper, more effective services than the NHS almost throughout the country. Okay. In my own area in West Sussex, there's quite abysmal services for ADHD, autism and the like, and yet people aren't allowed to come to me on the NHS even though I'm cheaper, etc., and better, I think. But I think the same thing applies here, that you're not going to be able to get specialist ME services going. The GPs, as you say, are not able to do it unless there's a change in the basic structure. I think it's great you've come, but I think the system needs to change, and I think there needs to be more competition. I actually think there should be more competition in a controlled way in the system, so that clinics like ours, clinics like an ME clinic can get going. I think it's confused by the virgin scaremongering, but in fact there should be competition in the system to allow you guys to get help. Thanks.
Hello, I'm an occupational therapist and I'm also an ME sufferer, and I'd just like to say that I work with rheumatological conditions and I'm very much a specialist, and a lot of our patients have got very complex symptoms like you have with ME, and yet their GP can't manage them. They just can't know everything about everything, and they're having exactly the same problems as we do with ME. And one of our jobs, and one of the things I'm quite passionate about, is if we can all work with all the ME societies that are there to support us and fight the government. There is a fantastic charity called National Rheumatoid Arthritis Society that we work very closely with, and they are actually a patient pressure group, and they work with us to fight what we need for patients. We know what we need for patients in the rheumatological area, but we want to fight together to help changes nationally. And if we can do that as an ME society, then I think we will be helping each other rather than like hitting up against each other.
Good. One down here, Pierre. One down here.
Some years ago, a system was set up where all over the country there were multidisciplinary clinics for people with ME, CFS. And these were a good thing, and they often comprised, in the multidisciplinary clinic, somebody to listen carefully, either a psychologist or a counsellor or something, a listening person, and very often a physiotherapist and or an occupational therapist. These clinics, of course, were not accessible to severely affected housebound people, but they were a start, and they were enormously useful. In the last few years, many of these have been closed because of lack of funding. Does Dr. Gerada think that there's any prospect that such multidisciplinary clinics may be set up again?
She will answer that one in a minute.
We're the parents of two children with severe ME. I've been ill since the age of 11 and 15, now 20 and 22. I thank you for coming and I admire you for coming. But there are issues around the way our children have been cared for. One of the issues we've had to deal with, because of their ages, is they've gone from being cared for by a paediatrician who was very, very good and very sympathetic, going through transition to adults. And the changeover between paediatrics, where you have one person coordinating their care, to the GP having to try to coordinate the care. But our experience actually is having very little power in terms of, for example, influencing the specialists, because now she has to contact various, because it's it's affecting various aspects, so the neurologist, etc., etc. And it's very difficult for her to actually coordinate that. She has very little power in terms of persuading, influencing how they're seen. My son, or for example, and I think this is partly the NICE guidelines' fault, in terms of being able to ask for further tests, appropriate tests to be undertaken. And I just wonder, can you comment on that issue and what's being done in terms of the transition, trying to improve transition arrangements for young people moving into adults, and the impact or the difficulties that GPs, I guess, themselves have in that regard?
Could you just a question, please, and a question. Okay.
The elephant in the room is that there are two very conflicting paradigms of treatment of ME/CFS. One paradigm is that it's really important to rest, and as every diagnostic thing says, exercise exacerbates the symptoms. One paradigm would say that we have to go down a medical route. The other paradigm says, well, and this is what the information to doctors is based on, and the NICE guidelines is based on, is the idea that it's started by a viral thing, but then you get really worried about exercise and you form false illness beliefs that you have a physiological complaint, and that the appropriate therapy is cognitive behavior therapy to get you to change your belief that you have a physical illness, and then graded exercise therapy to get you to exercise, and then you'll find out that it doesn't harm you. And I think that the anger within the field of ME is because most of us know that exercise will make us worse, and treatments which are according to the paradigm that I've mentioned will make people worse. And if specialist services are based on that paradigm, patients are not going to be helped. And I think that it's unfortunate that the information which your GP will get, if at all, will be based on that second paradigm. And if so, I don't know if Claire would have anything to say about
Yes, you will.
About that.
I'm going to ask Claire to try and sum up. I know her well enough to know she's a star. She can perform on answering, but she'll never satisfy everybody, and that's what I'm kind of worried about.
Why don't you invite me back next year?
She'll have a PowerPoint then, all the answers then.
The two people who referred basically to services, I want to say yes about the return of multidisciplinary teams. Do I have anything? I mean, if CCGs are going to work, they have to develop multidisciplinary teams in which we rather than sending patients to hospital where they end up going round and round in ever-diminishing circles. I think you, certainly through your charitable organisations, but equally through your ability to lobby, I think you need to be getting involved as far as you can, and collectively, as the lady from Occupational Therapy said, at CCGs. Now, I don't know whether CFS is going to be commissioned by the National Commissioning Board in England. I suspect it's not. So if it's going to be commissioned at CCG level, you've got 215 CCGs that you need to be influencing around getting services, which is about twice as many again as you had PCT. So it's going to be difficult stuff, but I think it's important. And we'll certainly be promoting some of the messages about multidisciplinary teams involving occupational health, physiotherapy, psychologists and whatever. The second about the transition, yes, you're right. It's the paediatricians that try to sort this out, and every disease that starts in childhood and ends into adulthood has the same problem. So cystic fibrosis is the classic example, in diabetes. And I think the gentleman at the back, who's from the Royal College of Paediatricians, you might want to grab him and ask him what he's doing. The lady here, I would be tempted to enter this debate, but I don't want to enter this debate because and I'm speaking now with my GP hat on, not with my Royal College of GPs and not with who you know I might otherwise be related to hat on. But my GP hat on, I often see patients where there is a debate in the background about causation. I don't mean ME, I mean all sorts of diseases. I started out, in HIV when they thought HIV was caused by, I don't know, but you remember? God, yeah. So it doesn't matter to me. It genuinely, and I accept that the paradigm will be different according to what modality one thinks, but actually what matters to me is what I said to you, which is seeing if I can help my patient. This morning I saw a patient with really quite complex fibromyalgia and all sorts of issues. What matters to me is not what's caused it, but how I can help her. Help in physical, psychological, social aspects, and help in terms of continuity. And if there is a debate that's going on in the background, then hopefully they'll sort that out. And if there is a magic bullet, drug-wise or whatever-wise, they've got to tell me about it so that I can make sure I can give it to my patient. But it's not my debate. It's not. It's too complicated and clever for me.
Thank you very, very much, Clare Gerada, for coming here.
Thank you.